All right, it looks like we have reached critical mass, so we'll go ahead and get started. Again, hi and welcome to the webinar. I would like to announce that this webinar is being recorded. I'm Jennifer Byrne and I will be hosting the webinar today. I'm a consultant for the Sonoma County Department of Health Services and have a background in population health management and quality improvement. This webinar is the second session in Quality Improvement in Dental Settings series. Hopefully many of you were able to attend the first webinar last week, but if not, don't worry. The webinar recording has already been posted to the COTAC website, so be sure to check it out. By completing webinar parts 1 and 2, you will be able to apply the model of improvement to improve the oral health of pregnant women, infants, and young children. This part 2 focuses on applying quality improvement methodologies in dental settings. Development of this training program and supporting resource materials was catalyzed by a grant from the U.S. Health Resources Services Administration, otherwise known as HRSA, to reduce the prevalence of oral disease among high-risk populations, specifically focusing on low-income pregnant women and infants. HRSA funded the Perinatal and Infant Oral Health Quality Improvement Project, aka PIOHQI, in 16 states to explore ways to increase pregnant women's utilization of preventative oral health care, increase the percentage of children who have dental homes by age 1, reduce the prevalence of oral disease in pregnant women and infants, ultimately reducing dental caries throughout early childhood, and reduce oral health care expenditures. Before we get started, let's take care of a few housekeeping items. Everyone is muted, so if you experience any technical difficulties, please use the chat box to connect with our experts for help. You can also use the chat box to share any commentary or any other communications throughout this presentation. We're asking that you please use the Q&A box specifically to ask questions that you would like addressed during the webinar or in an FAQ document shortly after this webinar. We'll use the Q&A box to periodically answer questions after each section as time permits. Finally, there will be a few opportunities for you to exercise what you're learning in real time. If you haven't already received an email from COTAC with the exercises, please visit the COTAC website and the link shown on this slide to download the exercises for use during this webinar. The email and the COTAC website also host a variety of tools and resources that will be referenced throughout this presentation and are meant to be tools or templates, if you will, that you can use independently moving forward. Okay, so let's dive into what you will learn today. After completing this training, you will be able to develop S.M.A.R.T.I.E quality improvement goals. We'll get into what S.M.A.R.T.I.E is, but it stands for specific, measurable, achievable, relevant, time-bound, inclusive, and equitable. You'll be able to create process maps using lean methodology, critically analyze process maps to identify improvement opportunities, and test small process changes using a plan-do-study-act cycle. You will also be able to identify, develop, and interpret data metrics to determine if a small change resulted in an improvement, explain how others have successfully applied a quality improvement approach to achieve measurable improvements. And as you may recall, webinar part 1 introduced the Sonoma County Perinatal and Infant Oral Health Community of Practice and how local health jurisdictions facilitated quality improvement efforts within their communities. Throughout this webinar part 2, we'll highlight real case study examples from that Sonoma County Community of Practice. Throughout, we'll refer to the clinic as Mount Rose Dental Clinic or another alias to protect the privacy of the participating clinics. And lastly, ultimately, after completing this training, you will be able to share the QI approach, tools, and resources with other team members and dental teams. Okay, so for those that weren't able to attend webinar part 1, it demonstrated why quality improvement is important in dental settings. Essentially, continuous improvement enables us to maximize our resources to ensure pregnant women and infants increase dental service utilization, which, as many of us know, if neglected, can impact their overall health and well-being. It has also introduced key quality improvement concepts to provide a framework or roadmap for your quality improvement efforts. This webinar will guide you through the useful tools and techniques that you may use to develop, implement, and evaluate your quality improvement efforts. According to the Model for Improvement framework, it's best to begin by asking, what are we trying to accomplish? So here's the cover page of a Plan, Do, Study, Act worksheet that was developed for use by the Sonoma County Perinatal and Infant Oral Health Community of Practice. If you haven't already downloaded, printed out this sample PDSA tool, please do so now. And by the way, PDSA stands for Plan, Do, Study, Act, if you don't recall. We will reference this sample completed PDSA worksheet throughout this webinar, but this webinar also references a blank PDSA worksheet that you should also download and print out now for use later on when you're planning your own quality improvement project. So we thought it would be helpful to see an example, which is what we're going to walk through together today. The first steps in the PDSA process entail developing the QI project's goals for the project, identifying the target population, and selecting the pertinent stakeholders involved in the process who should be engaged to participate in your QI efforts. Please note, while you can see here that clients are listed in the other category, they should never be considered as an afterthought. Their input is critical to improvement efforts, but as you can kind of see in the columns, they didn't fit into the other workforce categories, so that's why they're in other, but they're definitely very important. So before we begin, let's take a little quick poll. I'm gonna kindly ask Kiko to share the polling question now. But before we explain what it is, are you familiar with S.M.A.R.T.I.E approach to developing goals and objective statements? A is yes, I know what S.M.A.R.T.I.E represents. B is no, I've never heard of S.M.A.R.T.I.E. And C is kind of, I've heard of SMART before. If you could go ahead and answer now. All right, just a few more seconds and then we'll release the results. All right, so it looks like there's a big distribution here, which is great. So about a third of you have heard of S.M.A.R.T.I.E and know what it represents, which is fabulous. And some of you haven't, and that's okay. And many of you are familiar with the SMART acronym. And so we're excited to share with you what the IE stands for and hopefully build upon your knowledge base. Thank you for answering the poll. So, like I said, you may be familiar with SMART goals or objectives that clearly describe what you are trying to accomplish in language that supports measurement and accountability. S.M.A.R.T.I.E is the new acronym now in widespread use. Again, S.M.A.R.T.I.E stands for specific, measurable, attainable, relevant, time-bound, inclusive, and equitable. The new factors of inclusion and equity acknowledge their key roles in authentically addressing health disparities and to assure their consideration as core values that guide our work. So specific goals and objectives answer the questions, what do we propose to do? How will we know that we've accomplished what we proposed? They also describe the results or the end product. Specific goal statements and objectives are written in a way that anyone reading them is likely to interpret them in the same way. Measurable goals and objectives use accessible terms such as quantity, quality, frequency, costs, and deadlines. They describe the extent to which a performance target may be evaluated against a standard. Achievable answers the questions, can the team realistically accomplish it? Do team members have the knowledge, experience, and necessary supports to fulfill the expectation? Are there sufficient resources? A realistic time frame? Relevant answers the questions, is this effort aligned with our strategic plan? Should we do it? If yes, why? What is the anticipated impact? And time-bound answers the question, what's the target end date by which we want to accomplish our proposed goal or activity? So this is where it might be new to some of you. Inclusive answers the questions, does the effort engage the right people? Those whose roles, responsibilities, and perspectives are essential to examining and improving a process. It also asks, answers the question, have we taken the necessary steps to ensure inclusion of historically excluded people in a way that shares power? And finally, equitable answers the question, is this equitable for people with different needs? So an example of a not so SMART-I objective is decrease the number of dental appointment no-shows among pregnant women. It may be achievable and realistic, but the way it's written, we would never really know because it doesn't provide sufficient details, such as what group of pregnant women is targeted for the initiative, those at Clinic A, those who entered prenatal care by their first trimester. There could be a wide variety of answers. By how much do we want to decrease the number of no-shows? By 2%, by 5%, by 10 percentage points? What's the time frame for testing or intervention? 3 months, 6 months, a year? And where's the reference to traditionally marginalized populations and how this effort will address those inequities? So here's an example of a SMART-I objective from our case study from the Sonoma County Perinatal and Infant Oral Health Community of Practice. The multicolored row at the bottom of this slide shows how each of the SMART-I criteria are addressed in this case study example. So for example, everything in orange is the measurable component. This example reads, to increase the number of pregnant women receiving dental care, Mount Rose Dental Clinic will reduce the number of appointment no-shows among pregnant women when women referred by its comprehensive perinatal services program by 10 percentage points from a baseline, parentheses 67%, by September 30th, 2020, with at least 2% reduction among homeless women as measured by Mount Rose Dental Clinic's appointment scheduling program. See the difference? Okay, so let's take a few minutes to answer any questions you may have about SMART-I goals and objectives. CB, have we received any questions that you would like to share at this time?
Not yet.
All right. Well, again, feel free to use the Q&A box to submit any questions, but we'll go ahead and continue. So once the quality improvement team has determined what it's trying to accomplish, it's important to ask, what changes can we make that may result in an improvement? We'll explore several ways to help you answer this question. First, we'll walk through the process for developing current and future state process maps. Then we'll learn how to identify forms of waste. As you may recall, webinar part 1 demonstrated how Lean principles offer a valuable framework for conducting your quality improvement activities. Lean focuses on improving value from the customer's point of view by reducing waste. That is essentially the essence if you weren't able to attend part 1. Waste is defined as anything in a process that uses time and resources, but does not add value in the eyes of the customer. Customers surely do not want to pay for or be inconvenienced or harmed by this waste. Process maps are tools for analyzing the current state of a process or a product. This webinar will guide you through developing a process map, a useful tool to help you identify the 8 common forms of waste in a process. So to begin answering the question, what changes can we make that may result in an improvement, you need to plan your PDSA cycle. The first step in planning is to look at a process in its current state. The easiest way to examine your current process is through process mapping. A process map, also known as a flow chart, workflow diagram, value stream map, process flow diagram, there's many different names, offers a visual representation of the sequence of steps in a process. It helps us understand each step in a process, the positions and people involved in each step, and the expected output. Making the process visible helps the quality improvement team identify ways to simplify steps, improve inefficiencies, and decrease the opportunity for error. So why all this focus on process? There's a lot of evidence behind this, but studies show that at least 85% of the opportunity to provide customers with value in our process lies in our processes. There are additional reference materials on the 85% rule in the guidebook, which is available on the COTAC website if you would like to learn more about this. So before we dive in, here's some fun facts about processes. Nearly every tangible output, service, or product is created as a result of a process or a series of processes, also known as a system. Processes consist of steps that require and or consume resources, and characteristics of processes include repeatable, predictable, controllable, measurable, and generally triggered by, a request or a requirement. Over 85% of the opportunity to improve outputs while reducing cost and time lies within the process itself. The other 15% of improvement opportunities involves examining and aligning the organization's overall strategies and goals. Process maps are critical tools in quality improvement activities because they engage all persons with a stake in the process, and they replace pages of written word with a picture. They spotlight wasted efforts, delays, missteps, and duplication in the process undergoing examination. And they correct misunderstandings about a process, since one can visually see each step from the beginning to end. And through that process, they help build a common understanding and consensus within the team working on the change. This understanding is facilitated through the visual depiction of the current process that serve as to prompt open discussion about ways to resolve misunderstandings and identify opportunities to improve those inefficiencies. So what's that look like? This slide depicts the various stages of developing a process map. On the left, the first image shows what we think the process is, whereas the second image on the right shows what the process actually looks like. It fleshes out all of the steps in the process to fully capture the motions from beginning to end. By engaging key stakeholders in the process mapping working session, you help ensure identification of all parts of the process and possibly reveal steps about which some team members were previously unaware. Having a clear and accurate picture of the process in its current state is essential for identifying areas of waste that can be targeted for elimination through the team's quality improvement effort. The third image, kind of in the center on the bottom, shows what we want the process to be. The streamlined preferred process reflects the proposed outcome of your quality improvement efforts. It's efficient and isn't bombarded by excess waste in the process. So these are standard symbols that are used in a process map. You may use any combination of the following materials to develop your process map, but it's most important that you use what works best and is easiest to use with your teams. So what materials you could use include sticky notes, index cards, a large piece of flip chart paper, a whiteboard, or if you want to make it more formal, you could use programs like Visio or PowerPoint. Again, choose what works best for you and your team in the planning process. So what do these different symbols mean? Start with the oval process beginning or end shape when you start your process. Then use the rectangular shape to label each step in the process. Then add arrows to demonstrate the process flow from one step onto the next. The diamond shape can be used to label a decision point that could alter the process flow. For example, did the patient show up for her appointment? Yes or no? You can use the capital D shape to label a step that is dependent on some external factor that may cause delay, such as waiting for the patient to arrive before the dental assistant can adjust the chair and prep the patient for exam. Finally, organize steps into swim lanes to depict the role each person plays in fulfilling a step in the process. Each person is assigned a swim lane that's filled with the steps that apply only to them. So let me show you some examples in the next few slides of what this looks like. So here's a process map showing Mount Rose Community Health Center's perinatal appointment scheduling process. We call this the current state process map because it's the process before implementing a quality improvement project. So on the left here, you can see the different people involved in the process in their corresponding swim lanes. Here you can see the process begins with the patient calling the health center. Then there is a decision point where the process may change depending upon whether the patient is a health center member or not. The process continues, ending with either scheduling a future appointment when the patient is not experiencing pain, or with the dentist sharing the patient's dental program notes with the OB provider showing following a same-day appointment. So let's take a deeper dive into another process map. This process map will show Mount Rose Community Health Center's current process for scheduling perinatal dental appointment referrals from the clinic's Comprehensive Perinatal Services Program, referred to as CPSP. Again, we'll call this the current state process map because it's the process in place before their quality improvement project. So let me walk you through in more detail step by step. First, on the left, we have the different people involved in the process identified in their respective swim lanes. The process starts with the patient completing her CPSP appointment. Then the CPSP provider explains the health benefits of seeing the dentist while pregnant and recommends that the patient visit the dentist. Then there is a decision point. Does the patient schedule a dental appointment? If the patient does not schedule a dental appointment on her own, the process ends. If the patient does schedule a dental appointment, then there's another decision point. Does the patient show up for their dental appointment? If they do not show up, then there is no dental appointment completed. However, if they do show up, then they are able to complete their dental visit. Here are a few tips for constructing a useful process map. First, you need to assemble the team. Who should be on your team? Ideally, it should be a cross-functional, multi-level team. This means that team members should have sound knowledge of their respective part in the process. Together, they should also have the breadth and depth of experience to cover all steps of the process. Patient's perspective should be elicited too. In a complex process where someone has a limited role, have that person on standby or share their expertise at the appropriate time. And if possible, you can do this with your small team. You don't need a facilitator, but having somebody who's neutral who can help facilitate the activity is really helpful because it helps people who are engaged in the process on the day-to-day think outside of the box and really include everything that might have been omitted. Second, have the team agree on the process to map. How do you identify the process? Begin by asking, what are we trying to deliver to the customer? In this case, our patients. What is our end goal? Remember that your quality improvement activity should fit within your organization's strategic plan and ideally focus on providing value to the customer. Then decide together the beginning and ending points of the process you want to examine and improve. This is a very important step to avoid process creep that may result in describing complicated processes that ultimately may be difficult to improve, causing confusion, delays, and frustration. By knowing your start and end points, you don't try to solve for the world. You try to solve for that one process, right? Before constructing the process map, the team should also agree on the level of detail to be displayed for the same reason you want to pinpoint the process start and end points. To me, I might want to talk about every level of detail, whereas others might want to focus a little bit more higher level. And so understanding a clear level of detail to be displayed is important. And again, do what works best for you. Okay, so third, start process mapping. Brainstorm the current activities that make up the process. Write each activity on a sticky note or a card, use a whiteboard, and then put the activities into the proper sequence as you understand it. Draw arrows to show the flow, and then review your workflow chart with others. Patients, coworkers, other colleagues, to see if you need to adjust or change steps. Because again, despite all of our best efforts to get everyone at the table, you won't be able to do that all the time. And so it's okay to start with a small group of people that have availability and do your best, but then soliciting others' input is really helpful to make sure that process is accurate. And you can consider posting the process map in a public space for people to comment and make adjustments before finalizing, such as the break room or something like that, if you can't get everyone together at the same time. So finally, a few tips of what to avoid when developing a process map. Resist having one person or discipline complete the chart. You may miss valuable information pertinent to the process. And don't use a predetermined template, as each process is unique. Once you get going, if you decide to use Visio or PowerPoint or one of the fancier programs, you might be able to pull from the shapes so you don't have to recreate them, but you can't use a predefined template because every process is different. And avoid a common pitfall of mapping the ideal future state of the process rather than its current state. We all know what everything should look like, but how to get there is always the problem, right? And so this process mapping helps us identify the small tests of change to help us get to that ideal future state. So now you're going to apply what you just learned. I'm going to kindly ask you to get out a piece of paper, a sticky note, a pencil, whatever you have readily available to write with. You will use these to practice developing your own process map. The instructions for this exercise are simple. Using the skills you just learned, develop a process map for how to boil an egg. First, choose a start and end point, then decide what level of detail you will display. Brainstorm the activities that must take place for you to boil an egg, and then write each activity on a sticky note or a piece of paper. Finally, put all of the activities into the proper sequence and draw the arrows to show the process flow. So we'll give you about 5 minutes to complete this exercise, and then we will discuss our process maps when we continue. All right, so I know that was ambitious to ask you to do a process map in 5 minutes, but let's walk through our process map, and hopefully it gave you a good taste of the exercise. So here's an example of a process map for boiling eggs. We could have started the process as early as when the chicken laid the eggs, but that would have included a lot of details outside of our scope of control, and that ultimately would have had we ultimately would have had little or no role in improving, right? So we decided to start the process by getting the eggs out of the fridge. But again, this just emphasizes how important it is to make sure that there's clear guidance up front about what your starting and end point is. We then added a lot of activities required to boil the eggs: getting out a pot, filling the pot with water, putting it on the stove, and bringing the water to boil. However, we didn't go into a lot of detail here, right? We didn't say that you take the pot out of the stove, out of your cabinet, walk across to the sink, turn on the sink. You know, we could have went into much more detail. So again, understanding what level of detail you're going to go into a process map is really helpful. However, we didn't initially specify the type of boiled eggs we were preparing. They could have been soft or hard or a variety of different textures. This provided an opportunity to insert a decision point where the process changes according to the preferred type of egg we wish to make. And then we opted to conclude our process when the eggs were served. So hopefully this was a fun little exercise with something we all know how to do to show you how to process map. So now we have time for another poll. Was the process map for boiling an egg similar to the example we just walked through together? A, yes, no, B, no, and C, kind of. If you could just take a few seconds to respond to the poll, we would appreciate it. All right, so it looks like, again, there was a variety of results here. About half and half said that it was the same. Some said it was kind of, and some were totally different. And if it was similar, that's great. Obviously, we have a very similar breakfast routine, and if not, that's okay, right? That's why it's so important to have multiple stakeholders involved when developing a process map to account for all the differences that could exist. So now let's revisit Mount Rose Community Health Center's CPSP perinatal dental appointment scheduling process. Again, this process map shows how Mount Rose Community Health Center's dental clinic worked with the CPSP office before initiating their quality improvement project. This process, again, before any quality improvement efforts, showed a 67% no-show rate among pregnant women referred by CPSP providers. So something needed to change to make this process more effective. Mr. Shingo, a founding father of the lean production system, said, "The most dangerous kind of waste is waste we do not recognize." Process maps are ideal for revealing areas of waste in the process. So once you have developed a process map, always look for waste. Then you can start brainstorming ideas on how to reduce or eliminate that waste through a PDSA cycle. Oh. Sorry, a little technical difficulties here. We'll be right back. All right, sorry about that. PowerPoint opted to shut down in that moment. Okay, so I think we were just moving on to this slide. So Lean focuses on improving a process by reducing or eliminating waste. Actually, before I continue, CB, could you just confirm you can see everything fine?
See it perfect.
Perfect, thank you. Sorry about that. So again, Lean focuses on improving a process by reducing or eliminating waste. It employs a set of tools that help to specify the value desired by the customer, in our case, patients, identify the process for delivering a product or service of value, such as healthcare services, and challenge all of the wasted steps currently in place. It also helps to make the product flow continuously through the remaining value-added steps. It also introduces pools or dependencies between all the steps where continuous flow is not possible. And then it manages toward perfection so that the number of steps and the amount of time and information needed to serve the customer continually decrease. So there are 8 common forms of waste that are easy to remember by the acronym downtime, which stands for defects and rework, such as mistakes and errors in a process that prompt rework. Overproduction, such as unneeded reports or duplicative efforts. Waiting, such as delays in a process. And not used talent, such as not working to the top of your classification. The T stands for transportation, such as excess movement or product. The I stands for inventory, such as over or understocking supplies. The M stands for motion, such as excess searching for or gathering of documents. And the E stands for excess processing, such as signatures or approvals that aren't required or add value. So when you identify waste in a process, it's important to think about the root causes that result in this waste. Waste can be due to the fact that there's no method to prevent or catch errors, there is an ineffective design or layout of the facilities, there are fragmented or poorly designed processes, there are equipment failures, unorganized workspaces, or no standards or non-compliance with standards. And it can be because there's unbalanced workloads between staff. Waste can also be due to the fact that there is a lack of flexibility in the workforce. This is it can also be because there's inadequate or no training, poor communication, or no visibility into the performance of the process, right? If you don't know it's not working, how can you make it better? And lastly, that there is a lack of integrated systems and poor systems functionality. So as they say, every process is perfectly designed to get the results it gets. Mount Rose Dental Clinic had a 67% no-show rate among its CPSP-referred pregnant patients due to inefficiencies in the process. Creating a process map of what the process map looks like today helps identify the waste contributing to this unfavorable outcome. Let's look at the different forms of waste that appear in this process. So first, a lot of waiting occurs, one of the most common forms of waste. Remember, waiting creates delays in the process because someone cannot move forward with their activity until someone else completes their work. In this case, the dental front office staff waits for the patient to initiate the appointment, as well as to show up for the appointment. This waste hinders the dental clinic's opportunity to get the pregnant women the oral health care they need. Second, it appears that the CPSP provider has an opportunity to improve the application of their skills, an example of not used talent, which represents another form of waste. Currently, the CPSP provider only advises the patient to visit the dentist. This suggestion may not be acted upon and doesn't provide an intrinsic incentive for follow-through. If the patient has never been to the dentist, had a bad dental experience in the past, is afraid of the dental care, may be harmful during pregnancy, or any other number of barriers we know limit utilization, could prohibit them following through with scheduling an appointment. Navigating the patient to the dental clinic by helping her to make the appointment or by introducing her to dental staff before she leaves the CPS visit may just be the added touch that will improve the patient's dental visit follow-through. So after the Mount Rose Dental Clinic team identified the areas of waste to target, they brainstormed solutions for reducing and eliminating it. Together, they came up with a low-tech approach to reduce the amount of time dental front office staff spent waiting for a CPSP patient to schedule her dental appointment and to better utilize the CPSP provider as both a patient educator and a navigator. Let's take a look at their future state process map. Again, on the left, you can see the different people involved in the process and their corresponding swim lanes. It hasn't changed from our current state, so they didn't have to add anybody to improve this process. The process begins with the patient when the patient participated in her CPSP appointment. Upon completion, the CPSP provider asks the patient if she visited the dentist during her current pregnancy. If the patient already visited the dentist and has a follow-up appointment scheduled, then there's no need for a warm handoff and the process ends with scheduling her next CPSP appointment. However, if the patient has not seen a dentist while pregnant or does not have a dental appointment scheduled, the CPSP provider explains the health benefits of seeing a dentist while pregnant and asks if he can help schedule a dental appointment. The patient then decides if she's willing to schedule a dental appointment with the CPSP provider's help. If the patient says no, then the process ends with scheduling the patient's next CPSP appointment. However, if the patient says yes, then the CPSP office staff sends an instant message to the dental front office staff asking for assistance with scheduling a dental visit for the pregnant patient. Upon receipt of the IM, or instant message, the dental front office staff initiates a video call with the CPSP provider and patient. The dental front office staff introduces themselves. The dental front office staff introduces themselves, further explains the health benefits of seeing the dentist while pregnant, and works with the patient to identify a day and time for the pregnant patient's dental appointment. Upon confirmation of the preferred day and time, the dental front office staff books the appointment, marking the last step in this process. This proposed new process not only adds value to the patient through good customer service, it also leverages human nature. When someone knows the person they are accountable to, they are more likely to follow through on their commitments. By connecting the dental clinic staff virtually with the patient is more likely to show up for her dental appointment. Although this process map wasn't as linear as possible, it yielded amazing improvements, which we'll discuss in a moment. Which just goes to show, it doesn't have to be perfect. Just start with a small test of change. So after the dental team created their future state process map, they used the PDSA worksheet to further define their plan for running the test. They defined their objective, hypothesis, their action plan, or any required resources, and data collection plan in enough detail that anyone could replicate it. We'll go into the data collection plan in a moment, and you can further review this case study at your leisure. But before we continue, let's take a moment to answer any questions you may have specific to the process mapping exercises or anything before. CB, would you kindly read a few questions that have been submitted?
Sure thing. An attendee asks how to frame the S.M.A.R.T.I.E goal when we do not have baseline data for the aim. How can we make sure it is measurable? Do we estimate or omit the measurable part and don't clearly mention the percentage?
Thanks, CB. That's a great question for whomever submitted it. And we will take a deeper dive into the data component momentarily. But how to frame the SMART-I goal when you do not have baseline data for the aim. Quality improvement data is not the same data as data for research or data for evaluation. Quality improvement data should be very easily accessible and readily available, because you want to be able to do small tests of change on it and interpret that data to know if your change is resulting in an improvement. So your baseline data could be as simple as telling on a piece of paper how many women were referred today from your CPSP provider, right? It doesn't have to be something fancy where it's from an electronic report, nor does it really need to be validated. It just needs to be consistent. We will walk through a couple examples of data later that has been validated and can be readily used if you have that technology available. But ultimately, it's most important that you do define a measure and use it consistently to then tell over time whether your changes are resulting in an improvement. I hope that answers your question, and if not, feel free to submit another one. And we will certainly capture all of these great questions in our FAQ. CB, is there anything else?
Those are the only questions posed so far.
Awesome, great. Well, again, as you digest the information, feel free to shoot us another question. But that was a great segue to our next component, which is about data. So once the team has answered the questions, what are we trying to accomplish and what changes can we make that may result in an improvement, it's important to ask, how do we know if a change leads to an improvement? We'll now walk through the following topics to help answer this question: data for quality improvement, how to interpret run charts, and validated and or recommended measurements, and baseline data collection and ongoing monitoring. So Mark Twain once said, data is a lot like garbage. You have to know what you're going to do with the stuff before you start collecting it. Data for quality improvement purposes are typically collected by an organization to understand how the system performs by making the actual process visible, with process maps just one example of how to do this. It's also used to evaluate if the intervention resulted in an improvement by assessing the performance before and after the test. And that's why having any form of data for quality improvement is important, because you want to assess before and after your change. And then it's used to monitor if the improvement is sustained over time. Data for improvement are readily available, easy to obtain, and require tracking over time. Quality improvement data help pinpoint where to change a process to achieve improvement. So every process improvement effort relies on data to provide a factual basis for making decisions throughout their plan, do, study, act cycle. By collecting data, your team can assess the health of your process. Before launching a data collection effort, the team must identify the key quality elements that they will measure, how they will measure them, and what they will do with that data. This is known as the data collection plan. Uniformity in the data collection process is imperative. This entails developing a data collection plan that describes the data elements you will collect and their operational definitions, the collection methods and data source, that is where and how you will be collecting these data. For example, electronically generated data may be used when a report is routinely generated at the end of a week-long process and is easily already available. On the other hand, manually collecting data may be gathered on a daily basis for collating and reporting more frequently. Use what resources are readily available. That way you can get started with your quality improvement efforts. And finally, a data collection plan describes the period during which the data will be collected. For example, on a daily basis for the month of March, etc. There are different types of data that you could collect in your data collection plan. You can collect both qualitative and or quantitative data, and when combined, these provide information about the process. However, if you do have limited resources, quantitative data are preferred for quality improvement, because then you can use them to determine whether a change results in a statistically significant improvement. Quantitative data provide information that can be counted or ranked in order. Questions like how many services were provided can be answered and summed to result in a numeric value. Qualitative data provide information summarized or understood through themes and common responses. Questions like how did the change in behavior occur can be answered and summarized in non-numeric written format using qualitative data. So you can learn more about the different types of data in the CDPH Evaluation Resource Guide for local oral health programs, which can be accessed by clicking the link on this slide or visiting the CDPH website as well. So once the team understands the value of collecting data for quality improvement and how it differs from other data they might be already collecting or aligns with, it's ready to develop a data collection plan to uniformly track data over time. So let's walk through measurement examples that could be used to determine if the intervention results in more pregnant women getting oral health care. And this one was actually used by the Sonoma County Community of Practice. And there are other examples in the guidebook that you could also use, but we'll just walk through one today. So our case study aims to decrease the number of pregnant women referred by CPSP that miss their dental appointments. This example is the measurement that the clinic used to determine if their changes were resulting in an improvement. The numerator they used was the total number of pregnant women seen at the CPSP at Mount Rose Community Health Center who completed a dental appointment at Mount Rose Community Dental Clinic from September 1st through 30th, 2020, right? The denominator they used was the total number of pregnant women seen by the CPSP at Mount Rose Community Health Center who scheduled a dental appointment at Mount Rose Community Dental Clinic from September 1st through 30th, 2020. And again, this is the data that was easily available for them at this time and worked well for them. But if you had other data that was readily available, that would be okay, as long as it's consistent and can be measured over time. So now that the team has identified what to change in the process to reduce dental appointment no-show rates among pregnant women referred by Mount Rose Community Health Center's CPSP, they need to prepare to test the intervention. This is the do stage of the PDSA cycle. So first, the team members need to develop protocol for the new approach that describes how data will be collected. Protocol sounds like a heavy, fancy word, but really it's just making sure everything's very clear what you're doing so that way anybody else can repeat this. So the team decided that its electronic oral health record system would identify CPSP patients and run a monthly report of patients who missed their scheduled dental appointment. They also designated the CPSP health worker as the data entry clerk for this test. A team lead wrote the new protocol to serve as a brief reference guide and then trained key stakeholders to ensure that everyone followed the same playbook. They tested the data collection approach to ensure it worked. Once their approach, training, and testing were completed, Mount Rose Community Health Center and its dental clinic launched their PDSA test on September 1st and ended it on September 30th. They set October 8th as the date to reconvene, review the data collected, elicit feedback on their effort, and based on their discussion, they decided if they should adapt, adjust, or abandon with this new protocol. Before we take a look at one powerful way to review the data they collected, let's take a quick poll. So true or false? Data for quality improvement should be readily available, easy to obtain, and tracked over time. I'll take a few moments for you to respond. Awesome, fabulous. So it looks like the majority got the correct answer, which is A, true. The reason data for improvement should be readily available and easy to obtain is because you want to be able to act on it quickly to make changes. Quality improvement is all about doing small tests of change, incremental changes to make larger improvements. And the data for improvement requires tracking over time, so to make the performance of a process visible. To assess if a process changes, to assess if a process change results in an improvement by comparing data before and after the test, and to determine if an adopted change leads to sustained improvement. And we're going to go into a little bit more about how to look and analyze this data with run charts. So once you know what data you will collect, it's important that you are prepared to analyze and interpret the data in a meaningful way. Run charts are a powerful tool that help tell the whole story. A run chart is a graph that displays observed data in chronologically time-ordered sequence. It includes the title, an x-axis labeled with the time period, such as days or months, and then a y-axis showing the value of what you are measuring or tracking, such as appointment no-show rate or percent or something like that. The run chart also can be annotated with details that describe conditions that may have impacted performance in a particular way. So I always like to annotate my run charts with what change I was doing at that time, or something that was out of my control, such as the power shut off at the clinic, or flooding. Hopefully not, but something that was out of your control. We'll walk through the elements of a run chart together in a moment. So again, why track data over time? We do this to make the performance of a process visible, to assess if a process change results in an improvement by comparing data before and after your small test of change, and to determine if that adopted change leads to a sustained improvement. Understanding how to use and interpret run charts is important, so you may critically evaluate the factors contributing to success and supporting sustainability. So to produce a run chart, you will need your raw data, a goal line, and a median line. Your goal line is whatever increase or decrease you're trying to achieve as a result of your quality improvement project. For example, if you're aiming to increase dental service utilization by 10% among pregnant women and your baseline is 0, then your goal line will be constant at 10%. The other data you will need is a median line. The median is the middlemost number in your data set. To determine your median, you will organize all of your data points from least to greatest. The middle number is your median. If you have even numbers of data, then there won't be a middle number, obviously. So you will have to add the two most middle numbers together and divide by 2 to get your median. So again, let's look at an example. So here is a list of 7 raw data points. Now we have ordered them from least to greatest. And now we can see that the middle value is 14. So our median line would be constant at 14. So many of you are probably more familiar with a mean or an average. And you can calculate the mean by adding all of the data together and then dividing the total by how many data points there are. But the reason we don't use the mean is because it can be easily skewed by outliers. So run charts help tell the whole story. They include titles, an x-axis describing the time period of the data, which again should be in chronological order, a y-axis showing the value of what was measured, such as numbers of members served, percentage rate, dollar values, dollar saved, something like that. There's always a median line and a goal line. Lastly, the run chart can be annotated with details about what changes occurred during the time so that you can visually see what may have impacted those outcomes, right? So you see here, the current systems performance or their baseline was the June and July, and then they updated their EHR, which, caused some difficulties, it sounds like, because you saw a big decrease here. And then they updated their EHR and they got back to kind of their median again, and then they started sending reminder calls, right? So you can see all these different things and know exactly what was happening over the course of that duration of that run chart. So we created a how to interpret data template. This resource was emailed to all attendees and is also available on the COTAC website. The tool will help you input your raw data into Excel, and it auto-populates run charts with these components. But we also encourage you to enlist the support of your organization's data analytics department team or other QI experts, which will help you to advance the adoption of quality improvement approaches within your respective clinics. So let's revisit our case study example where the dental clinic changed their process using instant messaging between CPSP providers and the dental office. During their tests, the Mount Rose Dental Clinic observed a 35% decrease in dental appointment no-show rates among CPSP-referred pregnant women. So in this case, getting a decrease in no-show rates was excellent. This showed that their small change resulted in a measurable improvement. So tracking data over time helps us understand and classify variation in our data. A run chart is one of the easiest and most widely used QI tools for tracking data over time and distinguishing between special and common cause variation. These two types of variation are important to distinguish, so we'll spend some time walking through them together. Identification of special cause variation is particularly important because it leads to learning, because only when special cause variation is present can you conclude whether the intervention resulted in an improvement with statistical significance. So change is inevitable, even in statistics. Therefore, every process has variation. It's important to know what kind of variation is impacting your process because the course of action you take will depend on the type of variation you see. So again, there are two types of variation, common cause variation and special cause variations. Statisticians have different ways of describing and or measuring variability in data, and you may also have heard other terms. However, we will use these terms, common and special cause variation, as they are traditionally used in the quality improvement approach. Again, you can call them whatever you like, do whatever works for you, but we'll just use these terms since they're the foundation in QI. So common cause variation is the expected variation within a process. It's the natural inherent variation that will be present in every process. Common cause variation is fluctuation caused by factors that result in a steady but random distribution of output around the mean of the data. Again, this variation is natural, kind of predictable, somewhat stable, and quantifiable. Special cause variation, on the other hand, is unexpected variation that is due to a defined event. Hopefully, whatever change you're implementing, right? It's not part of the process all of the time and has an assignable uncommon cause. It's considered unstable or out of control, technically speaking, and is characterized by new, unanticipated, emergent or previously neglected phenomenon within the system. So that would be in the case if you weren't aware of all the steps in your process. The variation is predictable and falls outside of the historical experience base associated with the process. So again, only when special cause variation is observed may one conclude that the change resulted in a statistically significant improvement with a 95% confidence interval. This means that there's only 5% likelihood that the variation was due to chance. So when we say that this process has special cause variation present, then we know with 95% confidence that there was a statistically significant change. And then based on context, you determine if that change was an improvement. So common causes of variation are the usual variations in a system that are natural and inherent in a process. In short, common cause variation is naturally occurring variation inherent to the system, predictable within a given range and stable. So a few examples of common cause variation are on the right side of the screen. One example is normal wait times for an appointment or the amount of time it normally takes to perform a dental cleaning or exam. When only common cause variation is present, processes are termed stable. They're not necessarily good or bad, they just are, right? So this is an example of what common cause variation may look like on a run chart. As we know, dental cleanings on average take anywhere between 30 and 60 minutes. The amount of time it takes to complete a dental cleaning is a constant variable that is inherent to the system and is typically predictable within a certain range, right? This chart shows the average length of time the dental cleanings at Green Meadows Dental Clinic, and all of the values fall between 30 and 60 minutes, right? Therefore, we know this is common cause variation. when only common cause is present, process output is completely predictable to the extent that performance can always be expected to fall within a certain range. And this variation usually lies within 3 standard deviations of the mean, where 99.73% of the values are expected to be found. Now, I know I'm using some statistical terms just because I want you to understand the background and the science behind it, but ultimately it's pretty simple, right? Common cause variation is just something that's every day occurs within your process. So special cause variation is variation that is new, unanticipated, unpredictable, emerging, or previously neglected phenomena within the process, and evidence of some inherent change in the system or our knowledge of it, right? Identification of special cause variation leads to learning because only in its presence can you conclude with statistical significance whether the change resulted in an improvement. So again, a few examples of special cause variation are on the right side of the screen. Examples include computer crashes that result in an extremely long intake time, increased number of referrals as a result of launching an integrated EHR program that enables primary care, OB, CPSP providers, et cetera, to book same-day dental appointments for their patients, or a drastic increase in the number of appointments that must be rescheduled due to a dentist unexpectedly calling out sick. So this example shows a special cause variation. Typically, Green Meadows Dental Clinic completes 1 to 4 oral health assessments on children under 5 years of age on a daily basis. However, as you can see, on June 6th, Green Meadows Dental Clinic hosted a Give Kids a Smile event. By partnering with another clinic, they increased their capacity to see children. And as a result, they performed over about 300% more oral health assessments, which is noticeably outside their normal range. With special cause variation present, process output is completely unpredictable. It represents an inherent change in the system or our knowledge of it. Learning about this special cause variation would prompt a learning opportunity. Perhaps hosting these events more frequently or considering bringing on additional staff would help Green Meadows Dental Clinic meet its targets of conducting more oral health assessments on children under 5 years of age. So let's take a quick poll again. Which of these is the best answer to common cause variation is A, natural variation within a process, B, cause for alarm, or C, you don't know? Just give everyone a few moments to complete the poll. Awesome. It looks like everyone almost agreed that natural variation or common cause variation is natural variation within a process, which is excellent. So I see a few of you weren't sure still, and that's okay. This is new information, and we're throwing out some new terms. So we do have that guidebook and other resources readily available to help you continue to familiarize yourselves with this. And we have some upcoming exercises. So, but if you have any questions, feel free to enter them into the box and I'd be happy to help. So one more poll. Let's take one more poll. Which of these is the best answer to special cause variation is A, something new or unanticipated, B, variation outside of our historical knowledge base, C, present to determine if a change resulted in an improvement, or D, all of the above. And again, we'll just give you a few moments to complete the poll. Awesome. I know, this was a tricky one. I made it a double barrel where you had to read all the way through. So most of you got it correct, that all of the above is correct. So special cause variation is something new or unanticipated. It's typically variation outside of our historical knowledge base, and it must be present in order to determine if a change resulted in an improvement. So before we go on to discuss the different rules for determining if special cause variation is present in your run charts, let's take a few moments to answer any questions you may have on common cause and special cause variation. CB, are there any questions?
I don't see any at this time.
Certainly, okay. Well, again, I know I'm covering a lot pretty quickly here, so if you come with any questions, feel free to submit them now, and we can certainly address them in the follow-up FAQ. Okay, so there are several rules for interpreting a run chart that will help you determine if special cause variation is present. To apply each rule, you must calculate the data's median. Again, the median is the number that is halfway into the data set, which we discussed earlier. So there are two probability-based rules, shift and trend. Shifts are 6 points in a row that fall either all above or all below the median line. Points on the median do not cancel, nor do they contribute to the count towards the shift. Trends are 5 or more consecutive points, all going up or all going down. If the value of 2 or more consecutive points is the same, you only count the first point and ignore the repeating values. And then like or identical values do not make or break a trend. So I'm sure you've heard the word shift and trend used before. And they're commonly used indiscriminately on a subjective basis to kind of move a conversation forward, but this really does neglect their statistical significance. And so, it's important to understand their use in terms of the quality improvement. The statistical definitions we just walked through help us understand with statistical significance whether there's a 5% possibility that the variation occurred due to chance rather than by your change, right? Rather than your intervention. So these two rules help you understand with statistical significance, 95% statistical significance, that your change or whatever change occurred resulted in that improvement or unimprovement, right? Depending on what your interpretation of the graph. In addition, to conclude that a deliberate change to a process resulted in a shift or a trend, one must collect and analyze more than a single data point, right? You can't just make this determination with 5 or 6 data points. In fact, for you to have statistical significance inference, you must have at least 12 to 15 data points in addition to your baseline data. And so that's where, with quality improvement, you don't need to wait 15 months to determine if your change resulted in improvement because you need 15 data points worth of data. You can collect for 15 days and use that as your 15 different data points. That would work. Additionally, finally, we will discuss more of a subjective rule called the astronomical point, or more commonly kind of referred to as an extreme outlier. This is essentially a very high or very low data point that stands out in the data set and likely represents an error or a special occurrence, right? We call it an extreme outlier because it's not just the lowest or highest value. It's truly something that's very different. And lastly, it's important to note, again, only one rule needs to be fulfilled for special cause variation to be present in the process. So if at least one of these is present, then special cause variation is present. So let's take a deeper dive and look at shifts more closely and each rule more in depth. So shifts are 6 points again in a row that fall either all above or all below the median. Points on the median do not cancel, nor do they contribute to the count towards the shift. When seeking to identify a shift, consider the following questions. Do I have a grouping of points on one side of the median? Do I see 6 or more consecutive points, either all above or all below the median? What do I do with points that fall on the median? You ignore them and keep counting. Let's take a look. So this first example shows a shift. That is because they all fall below, they're 6 points below the median line. These next two examples aren't a shift because in each sequence, 1 point falls on the median line and they don't include the final point, which would only make them 5 points above or below the median. So a trend, again, is 5 or more consecutive points all going up or all going down. If the value of 2 or more consecutive points is the same, you only count the first point, ignore the repeating values, and similarly, like or identical values do not make or break a trend. So questions to consider if you think you see a trend. Do I see 5 or more consecutive points all going up or all going down? What do I do if 2 or more consecutive points have the same value? You ignore one of the points and keep counting. So again, let's take a look. So assuming the data points on October 1st and November 1st are the same, the first example shows a trend. The second example shows a trend, but it's missing the final data point in the trend line, which was included in the first example. So really, you might as well go for the first option. And finally, this third example is not a trend because 2 data points share the same value, indicating you could only count the first point in the count towards a trend. Therefore, there aren't enough data points in this example to constitute a trend. Okay, last rule, let's walk through. So again, astronomical points are an obviously different value from the data set, also known as an extreme outlier. They are easy to spot as the data tend to move along. Then you see a sudden spike or a dip, which causes you to wonder why. Extreme outliers often reveal one of 2 things. First, we may have collected the wrong data or inserted data that did not belong in our data set, or we might have had a typo. This is really a common explanation, so it's always important to check your data input. Or it could also mean that something special occurred, right? So note that every set of numbers has a highest and lowest value, like I said, so just being the highest and the lowest value does not necessarily make the data point an extreme outlier or astronomical point. When considering whether or not a data point is an extreme outlier, consider the following. Is one value clearly different from the rest? Does it reflect something that anyone working on the project would say is unusual? If not, is it common cause variation? So in this example here, you see an extreme outlier for how many oral health assessments were successfully completed at Green Meadows Dental Clinic in January. That's because the dental clinic hosted a Give Kids a Smile event on site and engaged other clinic providers to provide services and contribute to the event. So this extreme outlier would be considered an astronomical point because it is the correct data, yet different from the rest of the data set since it isn't a common reoccurring daily or monthly event. So again, we have a moment here to answer any questions you may have. CB, do we have anything?
I see no additional questions in the Q&A box.
Okay. Well, as always, keep them coming. So now we have some time to do another exercise where you can apply what we just walked through. If you haven't already downloaded the Interpreting Run Charts exercise so that you're ready to use it, there are 4 components to this exercise. The first 3 run charts follow the same instructions. First, we're going to ask you to eyeball a run chart to determine if you observe common cause or special cause variation, and if there is an evidence of improvement. Then we ask you to apply the run chart rules to determine if a shift, trend, or astronomical point is in the data. Then, based on what run chart rules you see, determine if you are observing common cause or special cause variation and whether there's evidence for improvement. Finally, we want you to reflect on your initial assessment. Determine if your interpretation of the data changes by applying the run chart rules. So like I said, this exercise was emailed to all of the attendees or is also available on the COTAC website. And we're at 11:20, so I'm gonna go ahead and give you guys about 20 minutes to do this exercise, and then we will resume to walk through the answers together. All right, well, I don't see anything coming in on the chat box, so I'm gonna assume everyone's ready for us to continue. If you feel like you need more time, just go ahead and enter into the chat box and we'll go ahead and take a pause again. So this is the first chart example. So hopefully by now you've completed this one. We'll walk through it and see what we can see in the run charts. So looking at the first run chart, when applying the run chart rules, we can see that there is no shift. This is because there are no 6 points in a row on either side of the median line. There is one positive trend. This is because from May 1st through October 1st, there were a total of 6 points in a row that were headed in the same direction. Because there was an upward trend, this is called a positive trend. And there are no astronomical points or extreme outliers. This is because there are no obviously different values. So now that we have identified the applicable run chart rules, we can determine what type of variation is occurring and whether there's evidence of improvement. So because at least one of the run chart rules applied, we can conclude that there was special cause variation. Because the change in May 2020 had a positive impact, we can say that there is evidence of improvement. So I'm curious if any of you looked at this before and thought there wasn't any improvement, but now based on this, based on applying these rules, you see how whatever change happened around June actually resulted in an improvement. Feel free to share your commentary in the chat box or Q&A. So now let's look at the second run chart. When applying the run chart rules, we can see that there are 2 shifts. This is because there are 6 points in a row, both below and above the median line. There is one trend. This is because from October 1st through March 1st, there were at least 5 points in a row. Here there are 6, all headed in the same direction. And again, there was no astronomical points or extreme outliers. And that is because there are no obviously different values. So again, now that we've identified the applicable run chart rules, we can determine what type of variation is occurring and whether that variation is an indication of improvement. So again, here we have 2 run chart rules that applied. So we know that special cause variation is present, and only when special cause variation is present can a change result in an improvement with statistical significance. And so because we see a positive trend, and the purpose here is to increase the availability of appointments, then we can say that there's evidence of improvement. So now let's look at the third run chart. When applying the run chart rules, we can see that there is, again, one shift. This is because there are 6 points in a row below the median line. And there's one trend. This is because from July 1st through November 1st, there were a total of 5 points in a row that were headed in the same downward direction. You should note that you should not include the astronomical point in your trend line, since it is a uniquely and unexpectedly different value. Which I guess just gave away that there is a astronomical or extreme outlier point. That is because the June data point was obviously different from the others. Here we can just use kind of rule of thumb that it was more than 10 data points different, right? So it seems like an extreme outlier. So now that we have identified the applicable run chart rules, we can determine what type of variation is occurring and whether there is evidence of improvement. Again, here we have all 3 run chart rules applying, so we know that special cause variation is present. And while for the purposes of this exercise, we didn't annotate the run charts, this example demonstrates why it is important to do so. There appears to be two changes that took place. The change on June 1st, 2020, prompting the astronomical point, was a change that clearly did not result in an improvement since wait times increased by 10 days, right? You would never want that. However, the change after that point, which prompted the trend and the shift, did result in an improvement since it decreased the days until the next available appointment. Okay, the last, let's look at the 4th and final run chart exercise. First, we finished plotting the line, the no-show rate for days 11 through 20 here. Then we added the median line at 4%, which is a constant shown in green. And then we added the goal line at 15%, here shown in constant form in purple. Finally, we added an annotation regarding the PDSA cycle on day 11. So here we can see that they made whatever change they were doing as part of their PDSA cycle. So then we started interpreting the completed run chart. We observed 2 shifts. This is because there are at least 6 points in a row. Here there are actually 8 below the median line and again above the median line. We also observed 2 trends. This is because we see consistent positive increases of at least 5 data points headed in the same direction from days 6 through 10, and then again from days 11 through 17. And again, there were no astronomical points. So again, since at least one of the rules applied, we know that the special cause variation was present. And since we see the daily rate of pregnant women seen in the dental office increase, we know the changes resulted in an improvement. However, the team does not yet have enough data to determine whether they achieved their goal or not. So I would recommend continuing to collect data for another week or 2 to see if the latest change enabled them to meet their aim. So back to our case study example, Mount Rose Dental Clinic. They implemented their test as planned, described briefly what happened, and offered a few points about the data. During their test, Mount Rose Dental Clinic observed a 35% decrease in the number of CPSP referred pregnant women who missed their dental appointments. They observed a shift, and they observed 2 trends in the data, 2 negative trends in the data, which in context of this project's goal were both good, right? Because they're trying to decrease the number of missed appointments. So this showed that their small change resulted in measurable improvements. After studying their results, they identified a few things that could be improved, like creating a job aid for the CPSP front office staff to remind them to initiate the warm handoff referral instant message after each CPSP appointment. As their next steps, they decided to adapt the change by improving upon it with their job aid and continue testing. After their next PDSA cycle, they actually reached a 0% no-show rate for CPSP referred pregnant women, which is amazing. And it just goes to show that you really have to do iterative PDSA cycles on top of one another that build on each other to really reach, ultimate improvement. But not, you won't be able to reach 0% all the time or whatever your goal is, and that's okay. The purpose of quality improvement is that it's continuous. You always have to keep going. We covered a lot of quality improvement skills, which would be beneficial for your dental teams to know, and we hope you will share these recordings with your teams and encourage them to view them. However, we understand they may not be able to devote enough time to review this presentation, so we have developed a quick start guide for their reference. You can hand over this kit to your team members so that they understand and can be actively engaged in the quality improvement process as well. The Quick Start Guide includes everything we kind of walked through today and in lesson 1 as well. It includes an overview of the quality improvement. It includes a Plan, Do, Study, Act worksheet, which we walked through a case study example today. We actually have the template, which is blank for you to use with just directions built in. And then we have the completed one so you can get a tangible example of what it looks like. And then we have a PowerPoint of how to develop a process map, which does include all the different shapes and symbols in case you'd like to use that. And then we also have the How to Interpret Data Excel template. So all you would need is your raw data, and then it would auto-populate the run charts so you can use them to interpret whether there's special cause variation and determine if your changes resulted in an improvement. So let's recap everything discussed in this training. Over the course of this webinar, you learned how to develop S.M.A.R.T.I.E quality improvement goals, develop and critically analyze process maps using lean methodology to identify QI opportunities, test small changes using the Plan, Do, Study, Act cycle, identify, develop, and interpret data metrics to determine if a small change results in an improvement. You're also able to explain how Sonoma County perinatal and infant oral health quality improvement community of practice case study applied a quality improvement approach to achieve measurable improvements. And lastly, now all of you know how to share these QI approaches, tools, and resources with your dental teams. So again, everything will be included on the COTAC website. All of these resources were emailed to you. This recording will also be on the COTAC website. But before we conclude, let's take a few minutes to answer any final questions you may have. Please take a moment to submit this at this time. CB, are there any other questions that have come in?
There are no additional questions.
Okay. Well, we would like to encourage you, as you continue to digest this information, to share any questions you may have that come up over the next few days to the dentalinfo@sonomacounty.org email address. CB, is it possible to share that email address in the chat with everyone?
Absolutely.
Awesome, thank you. So it will be included there. And again, we will be working on a FAQ question with any FAQ one-pager with any questions that come in, so we can address them for you. And then that will also be posted on the COTAC website. So the final slides provide an overview of additional resources that can be used for free to learn more about quality improvement approaches, methodologies, best practices, and case studies in dental settings. We strongly encourage you to check them out. They're wonderful resources and have been in large part the foundation of these trainings for you. So that concludes our presentation for today. Thank you all for attending. And again, the recording will be posted to the COTAC website shortly. Thank you.